We're live. I think, hello. We're going to have a chat as we talked about the immediate full arch work that we do,
Yep.
what it is. Um,
You straighten yourself up. Okay.
I am. So I think we talked about this and sort of mentioned very briefly, and I threw you into the deep end again and said, let's do a podcast about it, in which you
Sound
thought,
like you?
yeah, which you thought we were just going to record, and then I said, oh no, we're going to video it. So for those of you that aren't watching the video, it'll be on YouTube and on our social platforms if you do want to tune in. And those of you that want to just listen to podcasts, that's absolutely fine. Immediate full arch.
Immediate full arch. What else is it known as for people out there?
Yeah, all on 4.
Teeth in a day?
Teeth in a day. Smile in a day. All on 6. All on X. IFAL.
Yes.
ProArch. It's got lots of names.
It has. So ultimately, what does it mean? So when people see or in their dental practice, what does it generally mean? What's different to the routine everyday single implant placement to this treatment?
So this really is for a select number of patients that have a failing dentition, and they want to go from that failing dentition to fixed teeth in a day. Some clinicians will spread that out a little bit longer than that, but in a very rapid period of time. So there's no sort of interim denture or other prosthesis. They come in with their poorly teeth, and those teeth are removed. The implants are placed, and then the bridge it's prefabricated, or it can be fabricated after the implants have been placed, and then it's placed on the implants and screwed down, and they walk out with teeth. And because it has the term full arch, it's usually a full set, either a full upper set of teeth or a full lower set of teeth. And some people will do both arches, so they'll do the top and the bottom teeth in the same session. And that's how it differs to our conventional approach, which would be to place the implant after a period of healing. So teeth come out, there might be a denture provided, the bone heals. Then if everything looks okay and the implants are placed, and then there's another period of healing while those implants heal, and then fixed teeth would be eventually placed on those healed implants, which is a much more prolonged approach, the conventional way of doing it. And, there's nothing wrong with that approach at all. It's a very sensible approach. The immediate approach, was concept designed by Paolo Maulo back in the 90s. And it's proven to work. That's the important thing. It doesn't suit everybody. It's not for everybody. I'm probably yabbering a little bit more than I intended to answer your question.
Yeah. Yes, it certainly did. Certainly did. So what's the biggest, I mean, I know, but for those out there that might not, what's the massive difference between, we know that patients can have their dentition replaced with dentures, for example. So I know the difference, but having the IFAL work, the immediate full arch loading, as opposed to a denture. So what's the big difference?
Well, the teeth are fixed.
And that means that
you can't remove them. They're in. So it's a substitute for your natural dentition. So unless those teeth are loose and wobbling all over the place. But it's a solution where the teeth are screwed onto those implants and they don't move around. You can't take them out. The person that can take them out is the clinician. So they're locked on, and that's as close as you can get to having your teeth back.
Yep.
Essentially. So you go from really poorly teeth to being removed to having nice, I guess, shiny new teeth that you can, function with in a very short amount of time, if not on the day. So that's essentially what it is, getting rid of all those poorly teeth and putting a whole set of, a whole new lower set or a whole new upper set and fixing those to the jaw.
Yeah.
Whereas what we can do, alternatives are, and there's nothing wrong with these alternatives, because if you've got lots of bone left after the teeth have been removed, one solution is a denture, which is something you can take in and out. And for some people that works, and they can wear dentures quite comfortably. They have enough bone, so there's retention, stability. They may not need to use fixative. But in some cases, people don't want that. They don't want that as a solution. They don't want something they have to remove. Although it is an adequate solution for many people and possibly the right solution for some people.
Sure. And I mean, we're not even, there's conventional dentures, so that's without implants, but obviously there's also the option, or could be the option, of having an implant retained denture as well.
Yeah, and I think that's a really good option for many, many people. And this is where in the lower jaw you place 2 implants as a minimum. And then on those implants you have essentially the male part of a press stud. You still have to go through the conventional denture stage. It's not immediate. That denture is not made straight away because we need time for those implants to what we call osseointegrate and heal. So that's the time it takes for the bone to knit around the implant and lock it into place. And that's because we're only using 2 implants potentially. And then once they've healed, you can put these little buttons on top, these press studs as such. There are other things you can do, bars and other attachments, but we'll talk about probably a more common solution. And then on the denture, you can have these little clip-on inserts. They can be made of PEEK or nylon inserts. And essentially what they do is they cause the denture to clip in and clip out. So the denture still a denture, still take it in and out, still has a little bit of movement to it, but much less than a conventional denture. There's no need for fixative, or there shouldn't be any need for fixative. And that gives the patient an implant retained denture that they can wear, and gives them the confidence to eat some of the foods they might have been avoiding with conventional dentures. A much, very, very good solution for many, many patients. But there's a time difference in terms of the healing process. And the reason that there's a time difference and why you have these 2 implants in and let things heal is with the other concept. What's happening when that bridge goes in and those implants have just been placed, the bones still won't heal around those implants, they still won't integrate. But you're splinting the implants together. So you're splinting those 4 or 6 implants, or even 8, depending on how many implants have been advised or have been placed. And that bridge split, the theory is that bridge splints all of those implants, so those implants aren't able to individually move. And that micro movement on those implants can cause the implants not to integrate. Whereas if you attach a denture to 2 implants, as that denture is in function, those implants are moving very slightly. And therefore there's a higher risk that those implants wouldn't integrate. And that's why with the 2 implant denture technique, or 4, we would go through the conventional approach. So they'd be buried, denture would go on top, and some clinicians would actually place mini implants in the bone as well as those conventional implants, and use those as like a temporary implant. So that as the denture is being used, it touches those mini implants rather than going on to the bigger implants that we're going to use eventually. But again, I'm digressing. Sorry.
So jumping back to IFAL, so obviously immediate full arch loading. So that approach, it's been very, very successful, certainly for the patients that we've seen. And even though it's a cliche, definitely life changing. As with most treatments, there are drawbacks and there are maybe disadvantages, etc. Can we go through some of those?
Yeah, I mean, one of the probably one of the positives is the idea of this concept is you're avoiding grafting and you're angling the posterior implants and avoiding the nerves at the back and the sinuses at the top, which when people have lost many teeth, that's what we're kind of left with. So that's not a drawback, that's an advantage to the system. And I'm telling you that because I was going to forget to mention it. That's probably why I remember. And so that's the advantage. This system uses angled implants. and that's corrected. We like things to be straight, and that's corrected by the angled abutments that we can use. The disadvantages, it's quite a big surgery to undertake. So it's, you're taking the teeth out, you're putting the implants in, you might be grafting, you might be putting some bone back. You're then putting the bridge on in one go. And that's quite a big amount of work to have done. So, the tolerating that amount of work is fine, but it's not that bad. He says, not ever having it done, but it doesn't appear to be that big a problem for people. They tend to manage extremely well. Yeah, I think so. Yeah. We do it with a big team. There's a lot of pre-organized, there's loads of planning that goes on behind the scenes. So we make sure that everybody understands what's going on, and there's lots of care for our patients to make sure that throughout the journey, the beginning, the middle, and afterwards, that there's a lot of looking after. In terms of disadvantages.
So like issues, I suppose, is a good way of saying it.
There's an interim process. So we'll put a bridge on, and that bridge is pre-planned, and that pre-planning, it's with the way that we do it, and that bridge, that interim bridge, can be a little bit bulky sometimes, bulkier than maybe the patient expects. So it can encroach on the tongue a little bit or on the palate. So it might affect your speech very slightly compared to your natural teeth. And that can change, that changes in the second phase, but the first phase might be a little bit more bulky. The aesthetics in the first phase are limited. So because we're kind of guessing how everything's going to be to a degree, not necessarily a complete guess, but we're assuming the tissues are going to be in a certain position. We're assuming the implants are going to be in a certain position. And we're understanding, we're knowing where the occlusion is going to be. We can manage most of these things, but they can become an issue if we're slightly out. So we might need to make some occlusal adjustments. We might not have achieved the aesthetics that we expected. So we've then got that interim period where we're waiting. And then there's things that can happen from the interim before we get to the final one, such as, you can get the bridge fracturing on rare occasions. It's very rigid material, but it's an interim material. So we're bonding that to these little cylinders that go on the implants. And therefore we're not using, the material that we're going to use at the end, such as zirconia, if that's what we're going to use, which is a much stronger material. There are, some clinics that might do that. They might fabricate the bridge afterwards, but that takes a much longer time. So in other words, your provisional is zirconia, and that's a possibility to do. But we use something called PMMA, which is a very robust, strong material, and that enables us to get the patients with that provisional bridge very quickly. The screws can sometimes work a little bit loose, so we might need to, just tighten those up a little bit. Worst case, implants don't integrate, and that can happen. So integration's pretty much a given these days. But we might get the odd implant. You've got to remember that the patients that this treatment's for, they're usually periodontally compromised.
Yep.
So they've lost a lot of bone. They're susceptible to periodontal disease, and there's evidence that shows that susceptibility can have a negative implant or a negative impact on implants in comparison to somebody that isn't susceptible to periodontal disease. So, there's potentially a slightly higher risk that in these patients that we might get an early and a late issue. And that comes on to maintenance, but we could probably talk about that maybe towards the end, because these aren't fit and forget. They need maintenance, and we have a very robust maintenance protocol. So they need to be looked after. Patients need to learn how to look after them before they have the implants. We put them through a program, a pre-hygiene program, so they understand how to maintain the bridge that they're going to get, the temporary and the permanent one. And also, we try and get their mouth as clean as possible before we do the treatment.
Absolutely. And there's something I want to pick up on, because as you said with the aesthetics, so when we give that provisional bridge, what is fantastic about the final stage, the definitive bridge that they're given, is the patient has a chance to bespoke the bridge, if you like. So we're talking, where possible, obviously, the shade of the tooth, the shape of the teeth. And I say where possible because clearly, you know, there can't just be any movement with the teeth, because occlusally with yourself and with the lab, it's got to work. But it's great, you can bespoke that bridge to a certain extent for the definitive bridge, can't you?
So the second phase of the process. Patients wouldn't, you know, how they're getting along, if they've had any issues, if there's any speech difficulties, if there's any chewing difficulties, what they like and what they don't like. So we make notes of all that, and then we feed that back to Danny, technician, the magic man. And hi, Danny. And then, you know, we'll provide him with information. So we'll take the bridge off, and we'll go through a process of what we call indexing, where we're recording the new soft tissues, because they would have changed a little bit since the teeth were taken out and everything's healed. The position of the implants, the occlusion, the bite, and then what you mentioned, the color. The patient might want to change the color, and lots of different aspects. You know, whether we've had some speech difficulties, as I mentioned, if we need to adjust the bite, we send that information to Danny, and then he will send us back essentially a try-in, and then we take that temporary bridge off, we put the try-in in, and we have a little look at that and make sure that we are meeting the patient's expectations, as long as they're achievable, and that everything is okay clinically. From our point of view, everything's satisfactory from the patient's point of view, and then we're about to finish. But yeah, there's the patient's choosing what they want in terms of size, shape, within what they have.
Yeah.
So there are limitations to the procedure. It's a replacement for poorly teeth. You know, we're repairing what's been lost, and we're limited in some terms by what we are given by the patients that, you know, turn up.
Yeah.
So there are certain limitations, but we'll hopefully manage that from the beginning. You know, and explain what can be achieved and what can't be achieved.
Yeah, I think it's key in what you've just said, and you mentioned at the beginning as well. We are talking this kind of approach are for patients with poorly dentition, and as you said, it's not for everyone, for obviously a lot of reasons. So maintenance wise, so we've fitted the definitive, and you spoke about us putting the patients through pre-hygiene care when they've had the bridge fitted. Obviously, it's, as you said, it's fixed, so this isn't removable, so they don't take it out and wash it, clean it. So how can they keep that area clean?
I never thought I'd say it years ago, but water flossing it's a fantastic little device, a water pick, water flosser, for just popping that in between the transition line of where the bridge and the gum meet, and using that to flush it out. You can use super floss or little brushes just to clean around it. They're not completely self-cleansing. They do need to be maintained. They do need to be cleaned. You need, in my opinion, you need, you know, the water floss is good for the bulky material, and it's good to have something, but really getting something around those little abutments, whether that's, I hesitate to say super floss, or a little sort of interdental brush, and there are variations on those, and we advise different sort of types for the patient, and just getting that essentially where the implants project, so they're called the abutments, getting it around those abutments, just keeping those nice and clean. The way that the second bridge is designed as well, so the fit surface has to be designed in a certain way so that we can achieve that cleansability, or the patient can achieve that cleansability. And that's a little bit like the way that we used to fit the bridges, conventional bridges on teeth. You know, if we'd designed the pontic so that it had this concavity in it, like a denture, then that's going to collect food. So we will sort of work and Danny to design the bridge. Well, I don't need to get him; he knows what to do. But in the early phases, we used to talk about it and design that bridge so that it compresses those tissues very slightly. So I'm going off track a little bit, but it's partly in the design, partly in the patients to maintain it, and then again, coming back in and having a little look, checking everything visually, sort of probing where we can when the bridge is on, and then we'll take that bridge off as and when we need to. Periodic radiographs. Periodic removal of the bridge. Used to do it a little bit more frequently than we do now. Do it a little bit less. Reason for that is because there is some research that sort of suggests if you're continually taking that bridge off, then essentially you get a little seal. You get a little seal on the gum around the abutment, and if you're removing that bridge and putting that back on again, you're breaking that seal. So, in theory, it's probably better that you don't remove it as frequently as you used to. So we used to take it off a lot, pretty much every, 3 months, 6 months, 12 months, and then again, 3 months, 6 months, 12 months. Not doing that so much anymore. Taking off a little bit less, unless there's an issue, unless a patient reports something or something's a little bit loose or something feels wrong, not comfortable, or we're getting signs of some bleeding or there's an issue on the radiograph that we take, and then we'll take it off and look at everything. Did that answer your question?
It did. It absolutely did. Do you have any more questions?
Do I have any questions? Well, I think again, just to reiterate, this is for patients in the failing dentition, not for patients that have kind of got other options. I think if you've got other options, then you might want to consider those very strongly. So if there are several teeth that have a good long-term prognosis, then go for that. This really is the final solution. There's not much after this that you can do. I mean, I know we haven't talked about it. You've got zygomatic implants, you've got pterygoid implants, you've got there's some periosteal solutions now. And again, these are final solutions for patients. So I think that's how you've got to look at it, really. So, what I would do is sort of strongly say, if there's teeth with a guarded or a decent prognosis, then look at those alternatives, and consider this as the last resort, in my opinion.
Yep.
It's a good solution.
A very good
for
solution.
those people that need it.
Very good. I
We're there?
I think we're done.
Fantastic. Thank you very much. Cheers.
Thank you.
Thanks a lot.
Bye-bye.
Bye-bye.